So, I am Dr. Alan Barnes, and while I was, for a short stint, surgical tech in the operating room, handling instruments, and had only the usual intern experiences in surgery, actually in this hospital, I do not have any special knowledge in ICU or trauma care. So I'm so glad that Dr. Weigel is here, because part of my discussion is really, part of my talk is a discussion of the people here who do know something about trauma care and ICU, because you're there. And it's the issues are so very important. Traumatic stress is so much easier to prevent than it is to treat. So the problem is that the issues are vague and require a certain level of knowledge before you can begin to get hands-on and to know what you're doing in the direction that you want it to have an effect. What is stress? We use the word all the time. Stress is a perception, and it's got a negative connotation to it. But it's actually, if you take a look at it in the mildest form, it's why we learn to do everything. We know from our intellect, which looks at the past, what was. And then we're confronted with the isness of it is, what it is. We're the now, the here and now, and there's something different that you didn't expect. And perhaps a very small way, that is giving a perception that requires change. People do not like change for different reasons, until you find out that change can give you something better than you expected. And then you get into the excitement of anticipating change and moving toward it as fast as you can. So that's been called rushing toward the present moment. A word more about that, because it's central in everything we do. Here we are in a room, we're sitting down, and there's no movement. People are essentially placed, so am I, I'm standing here. And yet there's a huge amount of movement right now. Time is rushing by us. That's what's moving. Time. Now this is particularly important because in psychiatry we deal in the body, the mind, and also the spirit to the degree that it warrants. And with the mind, it is complicated, and there are different levels. The survival mind operates at the most basic of instincts to help the body survive. And the stress of that stimulates the chemistry of fear, and it focuses on survival at that moment. And also, there are changes that occur that are intended to facilitate the remembering of how did you survive. And that's so you can know that next time. So, remembering is useful to evade real dangers, but flashback memories, when there is not a real dangers, are felt with fear and panic, usually false alarms, and yet they cause great distress. And that's the part that's hard to treat. It's much easier to prevent. I'm going to go over the severe form, post-traumatic stress disorder, because it will be to a degree relevant, and in certain spots very directly relevant. It's from exposure to an actual or threatened death, serious injury, or sexual violence, because what it's doing is it is engaging in the most strong way the survival instinct in the body. and with that, the adrenaline system. And it comes from experiencing a traumatic event or witnessing it in person. You're seeing the event happening to others, as you might in ICU. It's not just the patients who have the stress. Or learning of a traumatic event of a close family member, a close friend, whether it's violent or accidental, or being in a situation of repeated or extreme exposure to the aversive details of traumatic events. Police officers, emergency room, ICU, trauma critical care. You folks are very much, we all are. This is a big we thing. We doctors are all in the same position with weighing every day what are the risks and what are the benefits for the patient. And we often use the guideline of, is it useful for the patient? We want to be patient-centered. We don't want to be diagnosis-centered. Now, why would that be? Well, a diagnosis is about thousands of people. But when you have one patient in front of you, you really have no idea where they would fit, this one patient, on a great big curve of all the people they saw in order to come up with that diagnosis. So essentially, we all start with one patient wondering, who is this person? And then secondly, our next concern or vital interest is, what is the situation they're in right now that they're responding to that may be triggering their past reactions, triggers of PTSD. There are intrusive symptoms because what happens is, I mentioned the memory of things. The memories come back, and what's happening is the mind is, this is apparently so. The mind is recycling in order to try to put the memory to balance. And the problem is it can't do that very well at all. And what happens is the memories are stimulated by five senses, and they give cues. These cues give a flash to the brain, and boom, if you're awake, it's called a flashback, and if it's at night and it's a dream, it's called a nightmare. And it wakes people, and many divorces have happened because the husband's back from the war. She wakes up and he's strangling her. Many divorces end right there. Well, he woke up in a nightmare. And somebody is in the ditch with him or in a trench, and he's protecting himself. Totally unconscious. There is an unconscious mind that operates in the background. It runs the body. It runs the basic part of the mind, which deals with survival. We can regard that as a survival mind. That is its purpose. There are dissociative reactions, flashbacks, triggers of memory while awake. So the five senses, from sounds or vision or smells are very strong, or other sensations to the body. It can trigger a memory of a traumatic event and bring forth the full response of the body as though one's life was imminently threatened. Like there's a tiger right there about to jump on me. There are mood symptoms, the inability to experience happiness, satisfaction, or loving feelings, often called feeling numb. This especially occurs when they're in a prolonged situation of stress they can't get away from, because the body will take over. And that unconscious mind will gradually come to try to protect itself by distancing somewhat from the sensations. And that's where comes the feeling numb. There's often an altered sense of reality, of self, or the surroundings. And now notice, does that have any relation, you think, to delirium? I think so. And then often an inability to remember an important aspect of the traumatic event, which is also unconscious. I'm going to stop and describe a little bit what that traumatic memory is. there are some cells in the brain that are called mirror cells. And they've been postulating what's the function of these mirror cells. Well, it seems to me that there'd be a probability that these mirror cells might be the way the body is causing the reflection, the echo of the event in some way, the sense, the perception of the event, which is then flashed out at the maximum. It's the quickest possible reaction a person can have. So what it does is it heightens your ability to get away from a predator. So the whole idea of surviving with this, if we were actually in a jungle and had to survive, or actually if you were in a wartime situation like Vietnam, for example, it could really be the thing that would save your life. There are also avoidance symptoms. When people see they're in a situation where there's not an everyday danger, then they begin to try to avoid these things, whether it's thoughts or feelings or whatever, that are somehow associated with a traumatic event. And they avoid external reminders. In other words, they're avoiding what's inside in the way of feelings and thoughts, but they're also avoiding external reminders that arouse distressing emotions, thoughts, or feelings. The sleep disturbance, nightmares, waking in a panic, nightmares causing sleep deprivation syndrome. Well, sleep deprivation syndrome is something that you get big time from delirium, or perhaps from sleep deprivation syndrome. There may be some causative aspects in terms of delirium. There's irritable behavior and angry outbursts sometimes when someone is feeling they're trying to protect themselves because of their misperception of where they are and what's going on. There's anxiety causing hypervigilance. People are on guard. They're watching every move you make. There's a reduced ability to concentrate with an exaggerated startle response, which is another way of saying the same things. Now, a moment here. Let's look at memory. How does one, I'll say myself, how do I know that I'm here right now? Well, the surroundings are the obvious thing that I see that tells me where I am. And I walked into the room, so it was already in this condition when I got here, so I'm not surprised by it right now as I look at it. But what I'm doing is, if, let us say I just walked in and I hadn't been here for a month, my mind would flash back to what it looked like, and I would pull it up I wouldn't do it. The unconscious mind would pull it up very quickly and would give me the information to know, yes, this is where I am. So the ability to retrieve memories is part of reality testing, a great big part. The ability to accurately perceive where you are. There are chemicals we know very well that distort our ability to perceive reality. People drink alcohol, and that has certain distortions in it. The first distortions relax anxiety, and after that it begins to diminish the sensory aspects. And there are other drugs. There are many drugs given in hospitals to help that themselves can cause delirium. Clinically, PTSD, the severe forms, can present as terror, and it's re-experiencing the fear. Panic, anxiety. Phobias are avoidance. Paranoia, which is mistrusting everything. Rage and aggression, anger, and hyper-irritable. Next, there's horror. People can have post-traumatic disorder by looking back on what they did. What have I done? Or what did I not do? Or what have I seen? And I should have jumped up and stopped that person. I had a patient who was in Vietnam, and They were not fighting, and there was a time when he was walking down a road and there were some guys, half a dozen or so, who grabbed a Vietnamese girl and were about to rape her. And he didn't do anything. And then he blamed himself for that ever after. And he had this, the horror plus grief plus the depression about it. But the crucial issue was, I asked him, well, if you had spoken up and tried to break it up, what would they have done? And he said, they would have killed me. And yes, that was Vietnam. There is pathological grief, a feeling of loss of something that feels like it cannot be regained. Ideals of oneself, one's ego ideal, or a place in a group. Now we come to an important one, dissociation. It's a disconnection from the trauma in one's mind. It's a literal disconnect of the mind so it doesn't feel it. It's like I'm not here. It's like from the mind's point of view, it's not here. So, do we have genes for that? Well, I'm sure. It's an unconscious thing. What do you suppose the deer feels like after the tiger has grabbed him and gotten him by the throat? Is he going to want to be alert to every little detail of that? I don't think so. So, dissociation is going to be something that I'm going to ask Dr. Weigel to talk about in terms of delirium. Because what if people are in this place, let us say they go to the surgery and they come out of surgery and they wind up and wake up in an ICU. Does that ever happen?
Oh, yeah.
Okay, yes. That happens. Well, if you've never been in an ICU and you wake up in it and you're in pain and maybe you have trouble breathing and all kinds of different things, tubes and lines everywhere, would you say, oh, good, I'm in ICU, they're taking good care of me? Would that likely be your response? I don't think so. No. And somebody is performing some kind of procedure, and this patient in great pain, like I said, looks at this patient and says, might say, why are you hurting me? And so what happens is the reality of this thing gets very turned around unless there has been some education previously, some exposure to something or other that educates this person before surgery that there are possibilities thereafter. A video might do that. Did they ever show videos of an ICU before surgery?
Not that I'm aware of.
Okay. Might help. So, continuing on the effects of the nightmares and the flashbacks, it causes a disturbance of the personality. Ordinarily, our personality is composed of, think large vines that come together to form the trunk of a tree. Okay, that's the personality. And sometimes they don't come together entirely. They're not balanced. And if the vine is unbalanced, it doesn't quite merge into the whole tree. And we see that as a pattern of personality or a trait and can be a disorder. Okay, so it's the unbalanced part of the personality. And in the stress of something, great stress, such as we're speaking about in the ICU, there could be a disturbance of the personality downshifting into some kind of trait or disorder. Also, major disorder. If we who are seeing people, whether it's in the psych clinic or elsewhere, don't rebalance this internal trauma, all are vulnerable to experience this downshift effect of depression. Low, exhaustion, low energy, I can't. People often self-medicate with alcohol and drugs. We know that. Sometimes people wind up in a state of helplessness because they're unable to imagine a new choice and they haven't asked anyone for help. Now that's often because they're very isolated. People sometimes suicide. And what they thought was, at least I can control that. It's my last choice. And it's going to be better. And it's very often a false belief. But if we aren't thoughtful about our patients, thinking of possibilities, it might never occur to us. I've had patients who never told me about suicide thoughts. And I was, on one occasion, it stands out in my mind, at first call when I was stationed with the Marines in the Navy program. And I asked this person, was he thinking of killing himself? And he said, yes. How'd you know? You need to be asking folks. There's terror, fear-based re-experiencing. Panic is a maximum fight or flight from what feels like imminent death. Feels like, perceived, okay? We speak all in psychiatry, we speak of, is it perceived or is it real? So, there's also anxiety, sensing there may be danger. That's what anxiety is. It's an alert to something that may be going sour, whatever it is. So anxiety is very useful. Panic's very useful. It'll get you away from the tiger. Rage and aggression is when the response is, it's a response to that perception of imminent threat, ready to fight. Phobias are getting away from all the triggers, and it's avoidance or mental emotional triggers of panic anxiety. If you're out of the comfort zone, if a person with this gets out of the comfort zone, they're quite likely to be irritable and get angry easily. And then worst case is they are out of things and they don't have any safe person, any person they can trust, and they have something very general called paranoia, and it's kind of like living in a small world I can control. High-level anxiety with this, and they are also all depressed. People can feel horror. What have I seen? What have I done? What have I not done? Like the example I said about the soldier who was in Vietnam and could do nothing about this girl being raped. Feeling that you have losses of values. In the military, they had a sense of loss of patriotism when they've lost trust in the officers or others. It's an injured sense of humanity, an injured sense of being connected to for all of us to be connected because we're all human. And again, we're back to dissociation. It's an unconscious disconnection as a relief from physical exhaustion or emotional pain. But however, then it feels like, and it seems like one is living in a surreal world, somehow stretched, strained. People can reconnect. If you watch horror movies, a lot of things they put on that are very exciting or whatever, frightening, are surreal things that look like they are almost real, but not. Pathological grief is the loss of love, the loss of sense of self, and again, it's a burnout thing unless it gets treated, to depression. Several items. When there is damage or collapse of the personality organization, and this can be a mild traumatic stress effect, with indecisiveness and slowing of assertiveness, people can get to burnout in, let us say, healthcare workers because of the work itself, and they can become indecisive with slowing of assertiveness because they have these doubts about things, and they don't have their usual personality that pulls them together. Remember the vines and the personality? When vines begin to pull apart, so to speak, when the patterns of personality no longer all pull together, then you can get this damaged sense of self with the inability to be confident and assertive. And again, it's a similar saying of helplessness when you lose that. And they need to be treated with respect, with their emotions regarded. Everything changes in small steps because everyone can do small steps. And that is actually how we approach helping someone with any of these problems, is begin with small steps that don't harm anyone, don't exploit anyone. And the, going on to depressive disorder in these anxiety experiences, there's a burnout effect. By giving calming antidepressants, all antidepressants are not calming. Some are stimulating. In fact, most are stimulating. Lexapro, Paxil was an old one that is calming, but has a lot of side effects, whereas Lexapro is a new one, an offshoot of Celexa, and has way less side effects. We use it a lot. And again, self-medication with alcohol and drugs is mentioned. We were talking a little bit ago, Dr. Weigel and I, that since the prazosin has been used to calm nightmares, and that was done up in the northeast coast. I think it might have been Seattle. And they came down and gave a presentation around 2002 or somewhere like that. And they were using prazosin. Well, in the military, it might take 5 or 10 milligrams, whereas in civilian use, it really works quite well at 3 to 5 milligrams. But it's necessary. It stops nightmares. That's what's so crucial. It stops nightmares. Because what it's doing is it's blocking the ability of the body to have the full-bore experience. So the person, it's kind of like they're seeing it in black and white, but it's not in living color, something like that. It allows people to recover from sleep deprivation syndrome. There are memorable patients we recall. One said to me, came in and on last visit, I prescribed that medication, and he had the lines were gone from his face, and he smiled. And he said, when I woke up the first morning after having no nightmares, everything looked different. If we don't stop nightmares, it will lead to dissociation or psychosis. And I'm regarding all of these rather than diagnoses. I think this is more like a syndrome that covers a lot more broad area, and we need to have, I think, the syndrome idea of we're looking for how does all this fit together instead of how is it different. Delirium. Delirium is similar to dissociation. Lorazepam, I find out in some of the reading I did for this, lorazepam interrupts normal sleep of REM dreaming, rapid eye movement dreaming. It interrupts that. And there are other medications that are tranquilizing in their effect that do not do that. So propofol also does that. And so the choice of medications is something that in the field of trauma critical care and intensive care, they have well-developed protocols for which medicines to use and which not. But the question is, are they being used? That's the critical question. Compassion and empathy. If a therapist, thinking psychiatry now, has compassion for this patient at this time, there is a connection there, an energy connection. The definition of love is the energy of connection. There are many different forms of love. There's love of the body, there's love of the mind and thoughts, and there's emotional connections that are just kind of neutral, connected but neutral. And compassion fits in there. But with compassion, begins to give faith. The connection, the patient begins faith to take the meds and give it a try. And if effective, that will build trust. And at that point, thinking of psych residents, when you have a patient who has had relief from the medications, it opens them up to accept some supportive therapy that you can do. Patients are not always open to trying small changes that might help them. If they have a hope that a new choice is possible, they will try. So, shifting to delirium. This is really widely known. I scanned a bunch of articles. And this is, I think I got this from Mayo. Reduced awareness of the environment with cognitive impairment, disorientation, memory problems. Their speech is not focused, wanders. Hallucinations, anxiety, mistrust of those trying to help, like I said. Irritability and anger. And then what's said it can take the form of restlessness or apathy. And my concerns are that if you've got 6 patients in the ICU, how many patients with ICU hold?
I believe 18 total.
Oh, my.
For the surgical ICU.
Okay.
The medical ICU, I think, is what, 12? And the neuro ICU has about 6, I think.
Uh-huh. Okay. Well, what I'm thinking is there's an awful lot to keep track of in a place like that with so many patients. And the whole thing is the patient with apathy, the apathy type of delirium, it's real easy not to pay much attention to that one. Very easy, because those who are restless and irritable and calling out and drawing attention to themselves are much more likely to actually get it. And then comes the disturbed sleep. Let's look at disturbed sleep a minute. Rapid eye movement sleep, called REM sleep, is a very important thing. And there's also slow wave sleep that's very important. And there are, it appears that those forms of dreaming are necessary for normal sleep that restores a person to a wide awake state and able to do everything we expect to do. We'll call it normal. But there are medications that disturb REM sleep and slow wave sleep. Lorazepam was all over the place in here, as well as propofol that does that. And then there's something else, dexmedetomidine or dexmedetomidine. Say it louder, please. Thank you. That mouthful it causes relaxation and normal sleep. Normal sleep. Is that one used here?
Well, actually, I'm going to defer to B, who's our expert on delirium. But yeah, we use Precedex, but we get a lot of resistance for using it because it's expensive.
It's expensive.
Although the price has gone down recently.
Wow. I wish the bean counter was sitting in here. Excuse me?
Family member have delirium.
Oh, better. Well, unkind, I'm sorry. But that would be an impression. That would really be an impression. There are implementation strategies that are widely seen. I scanned a bunch of articles, and I was reading very similar things in all of them. They recommend multidisciplinary education with routine monitoring for delirium. And I was surprised to read that it is not done routinely. That's scary. And then there's something called PAD that is a strategy for pain, agitation, sedation, and delirium. It's a medication focus. I'm sorry, your name is?
B.
B. Are they using PAD?
Sometimes. Not always consistent.
Uh-huh. And then there's an ABCDE bundle, which points out get them awake, get them to breathing deeply, and early mobilization. Are they using that? Sometimes?
We try, but it doesn't, it's just very difficult to do, particularly in our ICU setting. We do try.
Okay. Involving the family who are familiar and trusted is really vital. And here's what I would propose as one item. If there were a family member who fits that description, trusted and familiar, it would be ideal if they were sitting in a chair at bedside holding the patient's hand while he was waking up in the ICU the first time. Because he could wake up and say, "This looks like the horror movie I watched last night." And because if you have no, the mind can do things like that very easily, reflecting upon what you know. Sleep quality, REM sleep is very important. So also slow wave sleep. Very good things to know about. Use of stimulation, music, and I put the TV, but really I wouldn't say TV to regular channels, but rather a loop perhaps of soothing visual things and soothing music. Something of the kind so that the patient is not looking at all of the things he can't understand at all. Right? He could really look around and from his not knowing point of view, see this all as chaos, pure chaos going on all around. So, environmental controls, what they recommended was that there would be a time when sleep would be respected. And so let us say at 9 p.m. or something like that, or whenever the hour fit, that after that there would be no more awakenings of the patient for blood draws or any other thing until maybe 6 in the morning. And so they would allow them to have this uninterrupted time to sleep. And probably, if they had that, it would also have the effect of the whole place would be much quieter during that time. So, one of the things. Okay. And that is all that I have, but what I'm interested in is B and Dr. Weigel. I'm interested in how's it done here?
About halfway to what you said. I mean, we keep trying to get people regular sleep hours. We keep trying to get them awake during the day. I was always a big believer in TV, actually, because it doesn't take much brain power to watch it.
Lately, it's kind of crazy.
Well, we try to keep it off news channels.
Ah, okay. Good.
But, and B actually spends much more time there than I do. I've often thought that one of the problems that we have in the ICU with PTSD, and I've often thought, since I've been thinking about such things, that one of the activators of PTSD is a total feeling of helplessness, a total loss of control. And that's the first thing we do to somebody in the ICU. We take away their control of everything. We even have a Foley catheter in their bladder. They can't even pee by themselves. And I've often wondered if that isn't part of what's going on. We try to undo some of that, try to give them some choice, but that's very difficult to do in the ICU. See?
Well, our ICU, the trauma ICU is an open unit, which is great for nursing care, but terrible for patients because they don't get to sleep. It's very noisy. There is no privacy. Unlike up in the MICU where they actually have television, so that, how some older people watch the same shows every day, and so their day kind of goes by, The Price is Right, and then the news and whatever, and we don't have that. They can probably hear me. I got a really loud voice.
Well,
thank you. So, in the trauma ICU, because it can be a very chaotic place sometimes, it's really incredibly difficult for patients to sleep. Delirium is woefully under-recognized and it's woefully undertreated. And so frequently the solution is getting the patient out of the ICU up to the floor where they can actually get some sleep. And sometimes that is enough to help resolve the delirium. But my dad went through a terrible delirium when he had surgery many years ago, and it really stuck with me how difficult it is to see your loved one not be themselves any longer because of the delirium. And I really had to fight to help get him back into himself. And so it was a really traumatic thing for me, and really brought home how important it was to look for it and then, if possible, to prevent it.
And how did he come back?
He did. He actually had a parasupranuclear palsy, so he had some cognitive impairment anyway, but it took him almost a year to get over that delirium that he had. So, that's something that we don't always realize, is that delirium is not a benign thing, and especially for elders, they may not recover from it. They may not ever be able to go on back to living independently. That's also true for people who are younger as well. You've got an increased risk of death after delirium that can persist for up to 2 years after the episode, and so it's a really significant problem. And I think that it also contributes to PTSD, because people do remember being delirious, and it is a really horrible thing to try to remember all the nightmares that you had in the ICU of things that you thought people were doing to you.
Exactly. That was the point I was making about PTSD, and I think why it's directly connected to what you're saying, is that the brain is not designed to forget anything.
So there were, several years ago, we had an incident where a patient was convinced that she had been gang raped by the male nurses at nighttime. That did not happen. That did not happen. But because she was delirious, she perceived the input into her sensory that she was being raped. I think she was getting a bath or something like that. And so it's like that sort of thing, what a horrible thing to think happened to you.
Because she was getting a bath.
Right.
Uh-huh.
So how horrible for that patient.
Yes.
And how horrible for the nursing staff to have that stigma attached that, they gang raped her. Well, that didn't happen. So it's a really serious problem.
In the articles that I was looking at, the benefit to using multiple strategies, and they were the ones I mentioned, can reduce, in their studies, delirium by a third to a half. And that's huge. But I was just looking at, so many of them, they had different people who came in to do things. Physical therapists did some things, to the mobility and the breathing, and they had access to a lot of different people, and of course a budget to fit.
Yeah.
It's always nice to have the money to do through it.
That's the real issue.
It's a really important thing to look for, because it's got long-term consequences for everybody. It's a huge societal cost. I mean, the cost alone for annual cost for delirium is something like $165 billion a year. I mean, that's not just hospital costs, it's also in human costs as well. So it's a big problem.
And part of the problem is when you have hidden costs, that's kind of a hidden cost.
Yeah.
It's kind of like having the hidden problem of delirium when people don't see it and recognize it and realize that it's very important to have these strategies that are well worked out in the literature to use. So it seems like a area that's ripe for change.
I agree.
Thank you.
I have a statement more than I guess a question, but we will be reaching out to your department sometime in the near future as part of a trauma program, due to the fact that we are planning, in addition to working on the delirium side of stuff, but developing a trauma survivors network, and being able to set things up for them. And I'm sure that the two departments together will be needed to help meet the needs of these patients. Because we do have a lot of patients, and I only have the PTSD side of stuff, but when they leave here, they're not in the same condition they came in. And they may have been walking, talking, and now they're quadriplegic, or you know, any kind of different dramatic changes. And so just to give you this opportunity with so many in the room to let you know that we'll be reaching out, asking for some help to work with these patients as they continue their next step.
I'm sure the Department of Psychiatry would be happy to hear the, Dr. Kalam.
Now, we've talked about the trauma of being in the intensive care unit, and we also talked about the trauma that got them into the intensive. That's a double-edged sword, is kind of what I'm thinking.
Oh, yes, it is.
Was this a car accident or an assault or something like that? It's also,
See, imagining that, that trusted, close one that is in the room with the person, I think that one needs to be informed very much about the accident, whatever brought them in, and how this is, how the person's life is going to be saved. In other words, there was bad news, and the good news is everything that's being done is for the patient. And the patient's not going to get that message with a lot of the five senses. That's what's going on in the ICU. So to educate the close one, yes. Hopefully the close one is there in the room with them. I wonder, is it allowed to have someone sitting with them?
It is difficult because it's an open unit and privacy issues. So generally not. But you're entirely right. They don't know any of these people from Adam. They could be trying to hurt them. And for a family member, obviously they do know who that person is.
One of the suggestions made in the nursing thing I read was that the nurses would be trained specifically to this, and that you would think then that an ICU would have one person on site who had been trained in the recognition of delirium as well as the treatment. How many nurses at a time were there?
Probably between 9 and 10. Probably.
Okay.
Maybe 11.
Uh-huh.
And there have been education programs actually in the unit, small group for delirium. The trauma education program that we have for nurses also has a delirium component to it, so they've been exposed. But it's one of those things that you need to be re-exposed on a regular basis.
Yes. It's not the kind of thing that you're going to be reminded by something coming from the outside. Okay. Well, I think we'll stop.